Rishabh, your voice is not clear. Rishabh, your voice is not clear. Rishabh?
Hello?
Hi, Rishabh. Carry on.
Can you hear me, sir?
Yeah, carry on.
I think my internet connection has been bit unstable, sir.
Just carry on.
So would you like to introduce Dev Pujari, sir?
Yeah. So next slide. Rishabh,
Yes,
next
sir.
slide. Next slide. Rishabh, next slide.
Sir, next. Stop and restart the share.
So it's my honor and pleasure to introduce Professor Dev Pujari. He's a legendary neurosurgeon in the country, and we are very lucky as a students that we have him for our as a mentor. Today's webinar guru. As all students and participants are here as an example.
These are three candidates who will be on the student.
Rishabh, your internet is unstable. So
Sir, today. Yeah. Can we have Dr. Anish? Yeah. Anish, can you share your screen?
Yes.
Sir, I'll do something about it. Anish, can you just share your screen?
Yes, sir. It just says it's the host has disabled screen sharing.
yeah.
Okay, just a minute. Yeah. Can you share the screen right now?
So before Anish start, I would like to share the details that the timing is like 8 to 8:30 probably. The Anish will present the case of supracellular lesion, how for exam, and our Dev Pujari sir will going to give input, and after that we will have an advantage of our presentation of Professor Dev Pujari. He will show us the how to manage supracellular lesion, various type of supracellular lesion and their surgical approaches. So that's how program will going on. So Anish, please start with the permission of Dev Pujari, sir.
So can I start, sir?
After that,
yeah, you can start, Anish.
We'll have an advantage of.
Good evening, sir. I'm Anish from KIMS Secunderabad. Today evening, I'll be presenting the case of a 30-year-old male patient, right-handed, recent diabetic since 1.5 years, living at Ramvaram. He was the history was given by himself and supported by his father, and the history is reliable. He presented to our OPD with chief complaints of increase in the hand and feet size since 5 years, gradually, slowly, progressively increasing. He also complained of prominent forehead and cheekbones since the last 4 years. And since 1 year, he has noticed excessive sweating in both hands and occasionally feet as well. And also reports a decrease in sexual desire since the last 8 months. Coming to the history of presenting illness, sir, the patient noticed an increase in the size of his hands and feet since 5 years, and particularly the fingers and toes bilaterally. He reports that he was wearing a ring on the right middle finger for religious purposes, and because it was no longer fitting, he had to remove it and he had to place it on the right little finger. He also said that he had to change his footwear size from a size 9 to a size 10. In the last, this happened about a year and a half before presenting to the OPD. And he also reports a gradual increase in the thickness of the palms, especially of the palms, but on further questioning, he reports increase in the thickness of the soles as well. Patient, actually, it was first noticed by the family members that the patient had gradually, progressively increasing prominence of the forehead and the cheekbones of malar eminences since the last 4 years. Initially, the patient was unsure, but he also felt the same after several months on looking in the mirror. He also later on noticed a prominent protrusion of the jawbone and reports that later on his lower teeth was not as aligned with his upper teeth as it was before. Patient noticed excessive sweating in both hands since 1 year. He says that even when exerting mildly, like walking a short distance or cycling, he reports whatever he was holding in his hands, it slipped off due to this excessive sweating. And he has started to keep a handkerchief with himself due to the increase in sweating. He says that there is no increase in the generalized sweating of the body. It is mostly restricted to the palms and the soles. He also does not report any itching sensation or skin pigmentation associated. Patient reports a decrease in the sexual drive since the last 8 months. He's been married since 2009. He has 2 kids, a girl and a boy of ages 9 and 11. But since the last 8 months, he has lost quite a lot of libido and is no longer interested. My negative history, sir. Patient does not report any history of any excessive weight gain. He does not give any history of hyperpigmentation or striae over any part of the body. He does not give a history of milk discharge from nipple or any prominent enlargement of the breast. There is no history of intolerance to heat or cold, no history of any bowel disturbances, and it does not give any history of excessive thirst or urination. Patient has no visual symptoms. There is no blurring of vision or difficulty in seeing to the sides when he's riding the cycle. He has no history of any diplopia or ptosis or restriction of eye movements, does not report any headache or vomiting, and does not give any history of, this is correlated by the father, no history of any abnormal behavior or any altered appetite or sleep. Patient, I should probably elaborate. The patient was diagnosed with diabetes 1.5 years ago. He was not. He says that nobody in the family has diabetes. Patient says that nobody in the family has diabetes. He was diagnosed 1.5 years ago. He is only on oral hypoglycemic agents, and he reports good control with the oral hypoglycemic agents. It does not give history of any alternative medicine treatment or any other drug intake. Personal history, patient is on mixed diet. His appetite is adequate, sleep is adequate, his bowel and bladder habits are of normal frequency, and he does not consume alcohol or tobacco in any form. Past history, as I had reported, patient was diagnosed with diabetes 1.5 years ago and reports good control with oral hypoglycemic agents. Family history, patient, there is no significant history of similar symptoms in the family, nor are there any malignancies reported in the family. To summarize my history, sir, this is a 38-year-old male patient with an increase in the hand-feet size, prominence of facial features, excessive sweating of hands, and loss of libido, suggestive of features of acromegaly. Shall I?
Yeah, that's a proper summary. You have inquired quite a few negative history. So, can you give me reasons for asking some of the things like puffiness of face? I mean, this patient has already got some changes on his face. What is the purpose of asking about puffiness of face, and is there any history? Why it is going into a negative? Can you give me reasons for asking some of the things?
From the
like
history,
puffiness of
I could
face?
come to a
I mean,
provisional
this patient
diagnosis of
has
acromegaly,
already
sir.
got
Possibly of
some changes on his face.
one of the differentials would be a
What is the
central
purpose of
origin,
asking about puffiness of face,
pituitary.
and is there any
So I
history?
wanted to rule out any
Why it is going into a
hypersecretion
negative?
of
Can you give me
cortisol, hypercortisolemia
reasons
in
for
conjunction
some
with
of the
the
things
growth
like
hormone
puffiness
excess.
of face? Right. So this patient
You
you're trying to rule out if other
possibly
hormone
of some changes on
hypersecretion
his
is
face.
also involved,
One of
because
the
occasionally you
differences
can
would be
have
a central
plurihormonal tumors.
Yes, sir. So I wanted to rule out any
What
hypersecretion
do you think is approximate size of this tumor?
Growth hormone secreting tumor
Yeah, I think you
since
have
5 years,
established quite well that it is a secreting tumor.
possibly. Yes, sir. But he's been having symptoms since 5 years, so possibly a macroadenoma, but not very big, because it's not he's not showing any visual symptoms and no symptoms
So
of
lack of visual symptoms is very important. It has not been very prominently brought out, and the other eye symptoms as well. Jayesh, you have any other questions to ask?
No, sir. Just a very, very important topic you have raised, sir. Anish, how that cellular and supracellular, how you decide? What is your concept? Based on history, have you decided that you will say cellular or you say cellular and supracellular as a clinical diagnosis at the end of history? So that you can tell you.
Tell you frankly, I have concentrated on supracellular tumors today.
Yeah.
But I think this is very valid question. I think do you think this is just a cellular tumor or supracellular tumor? You have tried to answer it by negative visual history. But anything more than that? Can you be more clear than that?
It most likely is a cellular tumor, sir. The hormone secreting tumors are usually they present early due to their symptomatology, and they are not usually large on presentation. But and also there is no.
Not true of all hormonal tumors. Which hormonal tumors are usually large?
Prolactinomas.
Right.
And also there is no evidence in history of compression of the optic nerves or chiasm or trapsa, or no extension or into the cavernous sinus. Most likely a cellular tumor.
So basically, I think this is the beauty about cellular supracellular tumors, that you have really very little to go by. You are mainly talking about visual symptoms, and you are usually talking about hormonal symptoms. There is very little in terms of any other symptoms. But you have mentioned something at the end about seizures, abnormal behavior. Now, what is the significance of this? Seizure probably would represent some kind of a basifrontal compression in a large tumor. What about abnormal behavior?
Sir, abnormal behavior, altered appetite or sleep, I included to rule out any extension into the or compression on the hypothalamus, sir. or the
Without
stop
causing
insulin.
compression of hypothalamus, I mean, if you are asking for so much, then you should have asked for diabetes insipidus as well. But without causing compression of hypothalamus or without growing large, do you know of any pituitary tumor hormonal secreting which can present with abnormal behavior? Anybody else would like to answer?
Dr. Vibha?
Yeah.
So probably Cushing's can present with if there is a ACTH secreting.
Absolutely. So Cushing's is one of the syndromes where abnormal behavior can be frequently found without having any compressive symptoms, on the brain or hypothalamus. So you have fairly well established that you do not have a very large tumor and the patient has growth hormone secreting or acromegaly as you have called it so far. Any other questions from senior guys?
We have Atul Goyal sir also, he joined. Good evening, sir.
Good evening. Good evening. I didn't
Good
hear
evening,
the
sir.
whole story, but I heard some questions by Dr. Dev Pujari. Maybe I'd like to ask few questions about acromegaly.
Yes, sir. We have, sir, Dr. Vibha, we have Dr. Lakshya, and we have Anis as a student, sir.
Now, you know what I want to know from these young boys and girls, like growth hormone is it affects the function of the entire body. It is not just what you see like fingers and hands and face. You see these things, like you see the face, you see the fingers, you see the toes, you see the body. What you don't see is about the other organs which are inside, like heart, like gastrointestinal symptoms. I would like to know what are the systemic symptoms in acromegaly or growth hormone tumor. Can you just elaborate, and have you asked them in your history whether such things were present, and what are the very important non-cosmetic symptoms of acromegaly? I would like to know.
Atul, he has described that, but please go ahead. I think we have time. Just go back to describing your other symptoms.
Like, I would like to ask you, how frequent are cardiac symptoms in acromegaly? Can you answer that question?
Cardiomyopathy and increase in the JVP is there with acromegaly. Incidents, I'm not sure about the incidents part.
How common are the gastric symptoms, like pain in the abdomen, gastric muscle pain, and gastric symptoms? How common are these symptoms?
Not sure about the incidents.
Are they there or no?
Yes, sir.
Yes, sir.
In the other symptoms, have you identified if the skin texture, is there any change in the texture of the skin?
Sir, he reports dryness of the palms, sir, but also excessive sweating, hyperhidrosis, but no particular reporting of any oily skin.
So oily skin is a very common symptom, means it is almost always present. Means the feeling of oily skin in acromegaly tumor is almost always there. So you have to ask this question. On the forehead, is the guy feeling oily forehead all the time? I think these are also very important questions that one must rule out in the differential when one is inquiring into these kind of things. I'm sure you must have done it. I think rather than, please go ahead with your further in the progress. I will like to ask further questions after you finish, okay?
So Anis, here you, because you haven't, asked for gastric and that kind of symptoms, cardiac. So this is, you should note these things, very, very important. You go ahead. After negative history, you reach to the negative history, then go further. Right?
Another question I like to ask, if the person of acromegaly or growth hormone is left untreated, how will he die? Of which symptom he will die? Of which problem he will die?
Usually cardiac issues, cardiac arrhythmias.
So those are very important. You just cannot miss them. Okay.
Sometimes colonic malignancy is also there, each patient.
So that's another point. When we talk of organomegaly, we are also looking for possibility of various neoplasms. Do you have any idea? Are they more common than general population, and how frequent? How much more?
Colonic polyps and malignancy is more frequent in acromegaly patients, sir. Around 3 times more common.
Right. I think once we go to investigations, I'm going to ask you what is the marker for that. Go ahead with your examination.
Examination, sir. Patient is conscious, alert, oriented. On general examination, he has a prominent forehead and supraorbital ridges, a prominent zygoma with maxilla. Prognathism is noted with enlarged nose and lower lip. He has enlarged hands and feet with thick fingers and toes, and thick dry skin of palms and soles is noted. No particular skin tags or any other skin, this thing noted. On vitals were stable, sir. BP was slightly high. His febrile. His higher mental function was normal. Speech, intelligence, and memory were normal. The cranial nerve examination, the olfactory nerve was normal. The visual acuity was bilaterally 6/6. Visual fields were normal by confrontation. Pupils were bilaterally equal reacting to light, and fundoscopy was normal. Pupillary reflex was present in both eyes, both direct and indirect reflexes. The extraocular movements were normal and full. So 3rd, 4th, 6th nerves were normal. The rest of the cranial nerves were also normal, sir. Coming to motor examination, upper limb, the nutrition and tone of both upper limbs were normal. There was no motor deficit noted in bilateral upper limbs, and nor was there any motor deficit noted with bilateral lower limbs, sir. The tone and nutrition were also normal. The reflexes examination was normal. The plantars were both going downwards. There was no any sensory deficit noted. Patient did not have any cerebellar signs, and he had a normal gait. Sorry, this is my examination. I did not include the parabdominal or the respiratory system examination, sir, but it was done and it was normal, sir.
But I think at least you will have to talk about blood pressure, and you will have to talk about pulse rate, etc.
Yes,
you have done that. Okay. Okay, good.
So, Dr. Anish, would you like to summarize with the history and examination? What would be your final diagnosis?
Sir, my examination findings are correlating with my history, sir. This is a 38-year-old male patient with symptoms of prominent coarse face features and excessive sweating of bilateral hands and loss of libido, with the examination findings suggesting the same, showing features of acromegaly, sir.
So, Atul, you have any questions on examination? Anything more to be seen?
Not anything more, maybe some things less. Like, you know what, when you are giving a history, when you are giving a history of abnormal acromegalic features and all those things, and you start talking of higher function and olfactory tract and, other things, these are not, if you go on mentioning these things, you will make it hours long. You see, you can reduce other things. You can focus on what you are, eye function. You can focus on how is the vision, how is the hand move, how is the pupillary
Depend
thing
on
is
if it
okay.
comes as a short case or a long
Talking
case.
of, lower cranial, lower cranial nerves, if you start talking of hand weakness, now how come lower cranial nerve come into picture when you're talking of a very specific? So my suggestion will be, you just cannot have a routine kind of presentation like higher function normal, mentation normal, orientation normal. You have to focus on what is the issue and concentrate and heavily discuss that point rather than wasting your time in other things. This is what I would recommend for young people who are presenting. Even if you are, in exam and all, you have to not waste the time. If you start talking about, even in the history, I didn't hear properly, you said he lives in this village and that village. Now, how come village comes into picture in when you're talking of? So if it is not relevant, you can avoid all those things. You understand what I'm saying? This is my feeling.
Yes.
Any comment, Jayesh, or should we go ahead?
So, Anis, I guess any short case or long case, once you complete the examination, then there should be at the end, there should be anatomical substrate involved. And the last one should be a clinical diagnosis. And then you should move on radiology. At the end of radiology, there should be a final radiological diagnosis. And at the last, there should be a final diagnosis. So what you haven't missed, you missed it, the anatomical substrate and the clinical diagnosis. Now, clinical diagnosis here means cellular pathology or cellular and supracellular pathology, right? If it is cellular pathology, then it is secretory or non-secretory varieties of the tumor. So if you do better like that.
Yes.
So go ahead, say it.
So what is your clinical diagnosis now?
Sir, clinically, hypersecretion of growth hormone with
so growth hormone secreting pituitary adenoma.
Yes, sir.
The other question which was asked is cellular, supracellular.
Cellular, sir.
So very likely cellular.
Yes.
Okay, so how do you investigate this kind of a patient?
Sir, I would first like to go ahead with an hormonal analysis. Investigate with investigate growth hormone and IGF-1 levels, as other pituitary hormones as well, the T3, T4, TSH, prolactin.
Okay, so how do you what does IGF-1 level tell you?
Sir, it is a more stable marker of the, as growth hormone is more released in a pulsatile manner. IGF-1 is more stable, reliable and sensitive marker for acromegaly or gingivitis.
As other pituitary hormones as well, T3, T4, TSH, prolactin.
Okay, apart from this, you would do other pituitary hormones as well.
Yes, sir.
It is a more stable marker.
Any other subunit of growth hormone
reliable and sensitive marker for acromegaly IGF-1 levels.
Viva and Lakshya, you also can join and answer. You should unmute.
Okay, Viva and who's the third person?
Lakshya.
Sir, alpha subunit.
Alpha subunit. What does it subserve?
Not sure, sir.
Vibha, you have any answer?
No, sir, I'm not sure about the subunits. I mean, in this case.
I don't know. I mean, we've been doing it regularly. Very few units are doing it. IGF BP3. What does it? What is it a marker for? This is actually a more important subunit in terms of organomegaly and neoplastic behavior. So that marker is also considered fairly important, though most of the markers which we do are actually to substantiate our diagnosis and see the response to therapy, where this is not being used very regularly, but this marker we have been using regularly, and I think many units are.
Okay, sir.
One very basic question. Exactly what kind of growth hormone you would like to take, means once you write the investigation, exactly at what time, at which level, it's very important. You cannot take a routine random.
What time of the day?
Fasting growth hormone levels in the morning at around 6 a.m., sir.
6, I think, I'm not sure, sir. Dev Pujari, sir, Goyal, sir, is it fasting or 8 a.m.?
Usually 8 a.m.
Aha.
but fasting is recommended.
Okay.
Sir, is it something like the growth hormone and the prolactin is taken at 8 a.m. and the cortisol levels are taken at 4 to 5 a.m.? Do we need to send two different
Not that
samples
I'm
for?
aware of, because cortisol, even for diurnal variation, you usually take it 8 a.m. 4
8 a.m.
p.m. That is the current.
That a.m.
Okay.
But is there any simulation test like what you do for cortisol?
We can do
Sure.
a glucose tolerance test. We can do.
I do not think there is a established test like that. What is more important is you may have a patient where the growth hormone levels may not be very high, even if the patient has shown acromegalic features. What does that mean?
So can you repeat the question once more?
The patient has frank acromegaly, but the growth hormone levels are not high.
So, Vibha, Lakshya, any clue?
Because of the pulsatile nature of growth, but usually even then it is higher than 10 nanogram per ml.
Sir is saying it's
Maybe
normal,
one
not
reason.
higher.
Not sure, sir.
Sir, sampling itself, if someone's not in fasting status, there will be suppression of growth hormone after a heavy meal, for instance.
Sorry, please say again.
In case of sampling error, if they're not in fasting status, there can be suppression of growth hormone.
Dr. Dattatray Malik answered pseudoacromegaly.
What does that mean?
Dr. Dattatray, you can unmute.
Dr. Dattatray, can you unmute yourself and switch on your video to answer? Or anybody in the
Question is, what is
participant list who would
pseudoacromegaly?
like to answer this question?
What is pseudoacromegaly? Very nice question. Sir, you can highlight.
Pseudoacromegaly, I am not sure. I mean, some people have a protruding jaw, but I am not sure about this particular term. One thing I am aware of is Dr. Goyal there. Do you have any comment or should I go ahead?
You know what, in neurosurgery, we should not be pseudos. You understand? Huh? We should be, we should be true to what our job is.
Right.
Basically, we have to rely very heavily and we have to believe very heavily and have complete faith in our endocrinologist. Okay. That is one thing. And when they say there is a tumor, we have to believe even when you don't see a tumor on imaging, but when they say there is a tumor, like in Cushing, it happens all the time. They say there is a tumor, the tumor is producing this Cushing problem. So you have to believe in them. When they say it is pseudo and this is non-pseudo, actually, you just concentrate on your job. When they say there is a tumor and when you see there is a tumor, you have to remove it beautifully. That is your profession and that is your job. Being pseudo is not such a great thing.
Many a times there is some kind of a stabilization of disease and you may have growth hormone levels which are not substantially high, but IGF-1 always gives you a clue. Therefore it is more reliable.
The other thing that can be a pseudo thing is, when there is a growth hormone tumor and it produces acromegaly, and then there is an apoplexy and the tumor dies off because of the apoplexy, the tumor finishes.
So that is one explanation why the HGH levels can go low for some time or can remain stable. So stabilization of the disease has been
right.
And in those cases, should you be operating or not, I think you have to go by IGF-1 markers. Okay.
So can you go for radiology, sir?
Sorry, yes, please.
Okay. Anish, go for radiology.
Yes, so the hormonal analysis was
Yeah.
done first.
Yeah, please.
The T3, T4, TSH, and cortisol levels were normal. The serum prolactin was elevated to a mild degree.
Are you
IGF-1
surprised with that?
no, sir. Patient reported a loss of libido, so most likely suspecting high prolactin levels.
No, but do you think this is the this is the cause or effect of something?
Sir, it could be due to either the stalk effect, sir, a compression on the stalk causing loss of inhibition, or it could be like quite a lot of times the growth hormone and prolactin co-releasing tumors can be present.
Okay, go ahead.
This was a perimetry, sir. The peripheral field defect was present in all quadrants on the left side, sir. The right side was normal. The MRI and showed a pituitary lesion here, more towards the right side.
Can you magnify on your screen?
Yes, sir.
That is interesting. So this is an enhanced scan.
Sir.
First, keep it sagittal, and then describe it.
Yes, sir. It's not clearly prominent in this cut, sir. Sorry for the.
What is not prominent?
You can see the tumor quite well on sagittal images.
Yes, sir.
So what would you describe? How would you describe this?
Sir, it looks to be more than a centimeter long, a large pituitary macroadenoma.
What's the height, normal height of the pituitary?
Around 6 millimeters.
Upper limit is taken as?
1 centimeter.
1 centimeter. 10 millimeters. Yes,
1
sir.
centimeter. And what is the other criteria which is used? Usually the concavity is lost.
So yes, flat. Not yes.
So that has, go ahead. So you have to talk about these two factors.
So Vibha or Lakshya, you want to describe this tumor? Keep it in sagittal. You would look to add something?
You will have to talk about morphology. You will have to talk about intensity.
Anish, can you zoom in on the sagittal?
Yes, sir.
Changes in
Sagittal cuts.
intensity between T1 and T2 weighted images.
Yes, sir. This is a T1 weighted image. The tumor appears mostly iso-intense to the pituitary, sir. With more of a right-sided tumor and does not appear to be infiltrating into the cavernous sinus, sir.
No, for that you need the coronal images.
You should always comment on, in contrast particularly, that would you like to see the normal pituitary or not? Whether normal pituitary gland is seen or not.
Yes, sir.
So is it, where is that?
Normal pituitary is.
So what is contrast enhancing there?
Yes, sir.
It's a posterior pituitary, sir.
It's a dynamic scan here. Go ahead, sir. You.
So this is probably one of the earlier images into the dynamic contrast imaging, where we can see a normal posterior pituitary with the stalk clearly contrast enhancing, and there's a large iso-intense T1 iso and T2 iso-intense macroadenoma that is occupying the cellular region and causing the loss of concavity of the diaphragmus sella. Doesn't look like it is invading into the cavernous sinus by the looks of the images that are here. And there doesn't seem to be any significant supracellular or infracellular extension either.
So what is modified Wilson-Hardy score? So always you should stage like Wilson's, Hardy score grading.
See, I will like to little bit modify this statement. Statement is, he said that the posterior pituitary is displaced and all. Actually, what we have to, we don't know how much of the anterior pituitary is displaced. So you can state that this tumor is on one side, it is displacing the pituitary gland on one side. And you can clearly see the demarcation of normal gland and the pituitary tumor. And there is a well-defined, you see, these glands are nodular or well demarcated from the adjoining normal gland. So this is important to state that it is well defined. The normal gland is displaced on this side so that you can work on if it is on the right side, you can work on the right side and protect the normal gland. That is the purpose of the operation. And you have to be especially careful. So it is not correct to say posterior pituitary in particular.
Basically, posterior pituitary is not seen on it. I mean,
right.
you do not comment on it on enhanced scan. You have to comment it on a non-enhanced scan. And it should be usually on a sagittal image. So can you go back to sagittal T1 weighted image?
Yes, sir.
Now you comment on posterior pituitary.
Hyperintensity of the posterior pituitary is seen along the posterior superior aspect of the sella.
Correct.
Why hyperintense on T1?
The
Vasopressin.
Why the posterior pituitary hyperintense?
High content of phospholipids in the posterior.
Content of?
Phospholipids.
Sir, ADH, sir, antidiuretic hormone.
These granules, I can't quite remember the name. Those are responsible for the hyperintensity.
Yeah, phospholipid and cholesterol granules are there.
Are you interested in seeing the T2 weighted image?
Yes, sir.
So what happens on T2 weighted image? And what does it signify?
So sagittal T2 weighted image gives us basically an idea of the supracellular system, the third ventricular floor, if there is any compression on third ventricular floor, and also the vasculature that is in the basal cisterns. Those are the things that we are basically looking for, especially in the
change on the intensity of the tumor itself.
Oh yes, sir. So looks like it's a iso-intense kind of a tumor, and
what happens to it on T2 weighted images?
So we can look for cyst formation in T2.
So you look for any, I mean, does it become hyper intense at all, either partially or completely? What does that indicate?
Usually indicates a higher water content, and then the surgical resection can be a little easier, becomes more
Correct.
pliable and suckable.
Okay. And to do your Dr. Jayesh was asking you about the Hardy score. So would anybody comment on that?
Staging, Wilson and Hardy staging. Now we are using modified Wilson. Everybody is using modified Wilson and Hardy staging. Viva Lakshan is because that is minimum is expected in exam also, I guess, at the end. So
If you answer that properly, then we will ask you about Goel score.
we love to do that.
Hardy grade 1 because it's completely intracellular. There is no infracellular extension. Wilson B, I think.
So shall we talk about a little further looking at all this scan?
Yes, sir.
You are, this patient has come to you for opinion. What do you give him chances of cure?
So the pituitary adenoma seems to be of a relatively smaller size. He doesn't have excessive, the growth hormone levels are 7, growth hormone is 7, and he doesn't have any other features of systemic manifestations. So surgical resection would probably...
You talked about quite a few systemic manifestations. But you are saying that the cardiorespiratory system is not badly affected.
Yes, sir.
Okay.
So a surgical resection, around 80% of people can get and go in remission.
The other two guys have to answer.
I'm not sure about the percentage, how many, but a vast majority of patients will usually be cured, even of the systemic manifestations that usually reverse slowly.
Acromegaly surgical cure rate is 100%. If it is a grade 1 Hardy tumor. Viva?
So if there is complete excision of the tumor, then around 90 to 100%, depending on the amount excised.
Okay, I will ask another question. Now you have done a very good resection of the tumor. In the evening, you go and ask what kind of questions you will ask the patient and what do you expect after a successful surgery in the evening of operation? What are the questions you will first ask?
Does he feel any decrease in the size of the fingers and toes?
Good. Any other question?
I think this is the system got disconnected.
Not sure.
See, the first thing is, you know what? The texture of the skin. You ask the oiliness of the skin should go in the evening of operation. You say, my skin is looking better now. Then the other thing that even immediately the size may not decrease, but the movements may become free in the evening of operation. Movements of fingers, movement of toes, movements of legs. They become smoother and better. Not only in the evening of operation, when the patient comes out of anesthesia, if you ask how are the movements, he will say that they are better. So this is a growth hormone secreting tumor. Surgery is the answer. And if you have a surgical failure, then there is no answer. Then you have to give treatment. Drug treatment is not very effective. Radiation is not very effective. So surgery is very effective. Now I would like to ask you a question. For effective surgery, what are your parameters? How do you say my surgery is effective? You just cannot go and take a biopsy, right? You think you can take a biopsy? Is it a good operation? So what are the parameters that determine a good, successful operation? And what is the modus operandi? How you achieve that target?
So we can check the IGF levels.
No, not IGF level. Now during operation, I am asking you.
Okay.
Dr. Devani is saying that you should visualize normal pituitary all around.
And if there is no protrusion of the tumor on pulse albumin, you are.
No. This is very not a good answer. You see, now the thing is, what is a good surgery for Cushing disease? Where you can achieve 100% results have been reported. What are the parameters? And what is that parameter is not possible in acromegaly for growth hormone tumor? Or difficult, possible, but not that possible. Because acromegaly, the tumors are soft, they are milky, you cannot remove them as a nodule like you can remove in a Cushing disease. You have to remove the tumor as a nodule. Similarly, you have to achieve a radical resection in growth hormone tumor. If you have achieved a radical and complete as a nodule, you will be able to cure that person. And then you can talk of 100% and 200%. But if you have removed 50%, then you cannot talk of 100% result. So you have to know what you have to achieve. And you have to know how you have to achieve. And you have to know how you have to achieve a radical resection and a complete resection. 80% tumor you remove, he will never be cured. So you have to remove quite a beautiful resection that determines the outcome of these patients. You understand what I said?
So before we go for surgery, let's see what are our other options. Do we have any other options? Dr. Goel already said that other options are not so effective. What are those other options?
So medically can be the option of medical management is there, sir.
Like what?
Somatostatin analogs like octreotide or dopamine agonists like bromocriptine or cabergoline or pegvisomant can be given, sir.
Right. So which is the most effective and what is the success rate with this kind of a regime?
Most effective is a pegvisomant with the bromocriptine regimen, sir.
What's the likely success rate?
Pegvisomant is about 90% in normalizing the hormone levels.
And how long do you have to take it?
Basically needs to be continued, sir, until surgery can be performed, or otherwise, because it basically does not bring.
Right. So indefinitely.
Yes, sir. Receptor antagonist.
That is one major drawback, isn't it, in medical treatment?
Dev Pujari, sir.
When? Go ahead.
Sir, 5 minutes, we just reached at 9. Your presentation is still remaining. Okay. So we can sum up in 5 minutes, then we can start your presentation, sir.
Fine. So when do you actually use it? What is the current indication for using medical treatment?
There has been a recent publication related to the use of octreotide and invasion of the cavernous sinus of the tumor. And when the invasion is big, to reduce the size of the tumor, sometimes is achieved with medical treatment. However, we know that the surgical treatment is the optimal choice, but some authors like to use medical treatment to reduce the size of the tumor that invade the cavernous sinus. And after that, they perform the surgery, and they have had a good outcomes on it. That's also could be a tumor. A way to use it.
Is achieved with medical treatment. Any other? I think the first one you said is absolutely right. So if patient is unstable, patient is not fit for surgery, patient has a large tumor with cavernous sinus extension, you're not sure if you're going to, you will probably can tide over that period, maybe get a patient more stable before you operate. But the second most common is for some reason, if you do not see a tumor after surgery, do not see a proper target after surgery, then you will use the drug. If you think that the repeat imaging does not show any definite tumor and you do not have a radiosurgery or a radiation target, then you may use the drug. Anything else we need to talk about? How can you biochemically prove that you have achieved a good cure? What are the current criteria for surgery or success of the treatment? How do you assess that biochemically?
Normalization of the IGF-1 values or growth hormone level of less than 5.
So IGF-1 level takes how long to come down and HGH level takes how long to come down?
IGF level can normalize within 3 days, 3 to 4 days.
HGH levels actually come down on the same day. So most people are taking now 6-hour sample to say that if the surgery has been successful or not. And what is the cutoff level accepted by the American Endocrinological Association ACE criteria, which are currently followed all over the world?
Less than 5 nanograms per milliliter.
No, less than 5 nanograms was
2.3.
2.3 was in 2002. Today, what is the criteria? Today, it has to be less than 1.
Less than 1.
It has to be less than 1. For a successful surgery to be predicted immediately post-operatively, you need to have levels less than 1. What are the reasons given for not being successful, especially if you are not seeing a tumor on post-operative MRI? Last question, from my side at least.
Come on, Lakshya, Vibha.
So if there is ectopic focus in cavernous sinus.
Ectopic focus is not so common in acromegaly, in growth hormones. Anything else, Dr. Lakshya?
Not sure, sir.
Dr. Jayesh, you will answer or should I?
You, please, sir. You can.
So the most common explanation given is that in many of these patients, it is more true with Cushing's, but it is also true with acromegaly. The dural biopsies have shown that there are tumor remnants, either in the sella or more commonly in the cavernous wall. And this has been given as one of the reasons why it is not so successful. And these are the kind of patients where it is more common with Cushing's, as I said, but where people are talking about radiation of the whole field rather than, only the visible tumor, especially when it is not so visible.
Right.
Or medical treatment for these kind of cases. Anybody wants to add anything, Atul?
Go ahead, sir.
Yeah, this this dural invasion thing is a very important feature, particularly in Cushing disease. You see, when you are operating on Cushing disease, if you do a complete resection, you give new life to the patient. You completely change, cure. That word cure is used. On the other hand, if you have failed and the Cushing disease persists, many of these patients will not live for 6 months or 8 months or 1 year. So there is a possibility of completely giving new life to these people, and that depends on how beautiful an operation is carried out. And in that regard, one is radical resection is one thing. And the second thing which Dr. Devpujari mentioned is about the dura of the lateral wall of the cavernous, of the medial wall of the cavernous sinus and lateral wall of the sella. This dura is very, and dural remnants in that area have been described. Even a very recent publication has been there on the dural relationship. So what I like to do is at the end of the surgery, I like to scrape off the dura lateral to the sella, and that scraping has to be really, quite firm scraping. And that I think may be a very key factor in affecting a, giving a good outcome. So it is very important for us neurosurgeons to learn how to do this operation. Because it is not just doing an operation, it is because if you do half operation, it will never be effective. If you do 1/3 or 1/4 or 1/8 operation, it is not going to be effective. It has to be quite effective, radical surgery. And that in Cushing disease, in growth hormone tumor, because even in acromegaly, you can actually cure the person by your surgery. So you have to be absolute in these kind of situations.
Very, very crucial comment. So at the last, I would like to highlight that the growth hormone here is less than 7 and prolactin is 64. So there is two possibility. One is combined tumor. Sometimes, prolactin is not high, growth hormone is so much high, and prolactinoma and acromegaly would be the combined tumor. That is one, if Devpujari sir and Goyal sir is agree. And second, that there is a growth hormone, mild acromegaly, but with stock effect that leads to prolactin level raise up to 64. So this both can be the possibility at the end. We should think like that. Right, sir?
Yes, you cannot rule out, though I think though the HGH was not very high in this patient, the IGF-1 is fairly high.
Oh, right.
I feel that it is dominant, or it may be the main reason. And 64 is too low for it to call, plurihormonal tumor. So, but I think it cannot be completely ruled out. I agree, but I would go by the first thing that it is essentially acromegaly with growth hormone tumor, and prolactin is very likely secondary.
Right. So,
sir, I would like to ask, if we've done a hormone profile for the patient, we don't have an IGF-1 level. Like in this case, the growth hormone was near normal and the prolactin is not very high, but in the range of 60s. So would we go ahead with a medical treatment with bromocriptine, or should we go ahead with surgery because the patient does not have any visual symptoms but acromegalic features?
Rishabh, I think when the patient has so many features which are showing that patient has hypersecretion, we really need to investigate this patient. We need to probably repeat growth hormone levels, and I think IGF levels are really crucial in clinching the diagnosis. Way back when I mean almost 25 years ago, one of the first lessons I learned was a patient I treated for acromegaly whose growth hormone level was only 3. And we did IGF-1 levels, which we had just about started at that time. I'm talking of early 90s, and they were like 700. And that is time I have come to understand that that is probably more important. And you can get, there is a nomenclature in endocrinologist's book called burnt out acromegaly, where the patients stop growing any further after achieving a particular kind of a level. And in those cases, the IGF-1 levels also are not high. And there you can probably either treat them conservatively or medically.
Okay, thank you, sir.
Dr. Ankit has
asked. We have one question in the chat box.
Yeah, Dr. Ankit has asked to Goyal sir that please tell us how will identify intraoperatively that the resection is good or complete. I think sir has already answered that you should scrap the dura at the end. At normal.
Scrap the dura, and on the gland side also, usually you get a very good plane. There are very few tumors which are purely intracellular where we will not get a plane.
Right.
The problem comes in very large tumors where you really need to exert, and you need to have a lot of experience to differentiate between normal and abnormal. And I think if you have a Cushing's or acromegaly in a patient who has gone past beyond age of having children, you can probably take out some gland with it. You are allowed to do that.
I will just like to repeat, because it is so important. And it is not only important, it is crucial and game changer. What determines radical resection? You see, in non-functioning tumor, the issue is different. In functioning tumors like Cushing and acromegaly and growth hormone secreting tumors, radical resection is the key to success and key to giving new life to the person. And acromegaly, as Rishabh, you were saying, whether we can conserve an acromegalic patient, it is not possible to conserve a person who is acromegalic and is showing on his face acromegaly. You see, it is a killer. Growth hormone tumor is a killer. It is not just face that is being affected. Whole body, he will have pain in the body. You ask him first symptom, he'll say, doctor, my whole body is paining all the time. You see, it is a killer disease and you have to treat that disease. So in effect, the Cushing disease are microadenomas. Even this tumor is a kind of a microadenoma. And microadenoma, if you see this tumor, which has been shown here, there is a beautiful plane of dissection from the tumor and the normal gland. You can see the normal gland and you can see the tumor on the image. And that differentiation of normal and abnormal is the key to success. In Cushing disease and in growth hormone tumor, that normal and abnormal and that nodule. You see, there is a very famous neurosurgeon, Oldfield, Ed Oldfield. He's he is dead now, but he introduced that we should remove Cushing disease as a nodule. And that has completely revolutionized treatment of Cushing disease. From whenever we used to talk of Cushing, nobody in the world used to talk of more than 60% cure or 65% cure. But now you can talk of 100% cure, because if you have the capability of removing it as a nodule, you see that nodule kind of resection is not possible in acromegaly, in growth hormone tumor, because these tumors are soft and milky tumors. But you first debulk and then you remove the capsule of the tumor. There is a pseudo capsule around the dome of the tumor. So you have to identify the plane and you have to remove the plane. And I have to say that it is quite easy, not easy, nothing is easy in neurosurgery, but it is possible. And to do a resection is very important. You have to learn it, and you have to learn it over a period of time, over several cases. So you have to learn this technique of radical resection.
Thank you so much, sir, for this comment. I think Dev Pujari, sir, I think we should end this thing, and we are very grateful to both of our teacher, Goel sir and Dev Pujari sir, that we learn a lots of things, very crucial points of the supracellular pathology. Now I would like to request Dr. Dev Pujari sir to share his experience.
I mean, if you can unshare, Anish, please.
Yes, sir.
I think what I have done actually is I have changed my presentation because I thought it was mainly on clinical presentation. So I have actually omitted treatment completely. But we'll see what we can do. We can talk about that as well.
We are very excited, sir. Please.
So basically what I'm going to do is just talk about a few basic things before we go into the so what is cellular supracellular region? I think we all take it for granted, but just to define the boundaries, we are really talking about the sella, the bony and the sinus structures around the sella. We are talking about the stalk. We are talking about the, diaphragma cellae. We are talking about the floor of the third ventricle. And we are also talking about the optic apparatus, which is very, very intimately related to all this. And maybe we are also talking a little bit about the cavernous sinus, though all of these are topics by themselves. I think we need to consider this when we get a clinical case of cellular supracellular tumor. And some of the essential things which you must understand is what is the blood supply in this area for the optic apparatus, where does the blood supply come from, and this becomes very, very important when you decide on what kind of surgery and where you are going to operate and what you are going to remove from where. Diaphragm ocella also is a very important concept that we know that it's a small circular fold of dura mater that forms the roof of the cella, but it may have only a small opening. It may have a large opening at times. And as Dr. Goel repeatedly reminds us, it's a very, very firm structure, and it gives us a lot of scope for manipulation and removal of pituitary tumors, even if they grow very big. Other things you must understand is the blood circulation to the optic apparatus, blood circulation to the infundibulum, and this is a very, very important concept, especially for people who are going to take up transphenodal surgery as one of their main interests in life. So basically, we are talking about the region above the cella with the anatomical structures of hypothalamic pituitary system and the visual pathways. When we talk about this, apart from the circle of Willis, of course, which is surrounding it all over. And here we are talking mainly, as surgeons, we are talking mainly about mass lesions and occasional vascular lesions. And these can be right from the desembryogenic origin, like craniopharyngiomas, epidermoid cysts, dermoid cysts, trachea cleft cysts, and rarely hamartomas and germ cell tumors. And tumors originating from supracellular structures like the gliomas from the various parts of the brain we just talked about in this area. And of course, the skull-based meningiomas which grow into this area. And then there are some tumors which grow primarily in supracellular space and then probably invade the cella very, very rarely, and very few systemic diseases can also be important. We also need to be very, very careful, especially as I told you from surgical point of view, to understand what is the relationship of the lesion to the internal carotid arteries and to the circle of Willis. And here I think it helps a great deal to study your radiology properly. Apart from the tumor itself, you need to look at these things also quite well. And especially for transphenodal surgery, you need to know the anatomical variations of various paranasal sinuses and how the carotid artery can be sort of, traced according to those eminences. The most important visual deficit which we see in these patients with supracellular tumor due to a cellular supracellular, the kind of tumor which we saw today, if it was growing further, what they produce essentially is the bitemporal hemianopia, which is the type of partial blindness where vision is missing in the outer half of both the visual fields. And this is caused by lesions which are usually affecting it centrally, and from below or from above is different, but we'll just get to it in a moment. So I think as a neurosurgeon, there are several ways. If Dr. Nair is teaching, he will tell you 10 other types of visual field, how it is compromised. But I think you need to understand at least 3 major issues. That if you have an optic nerve lesion, you will have a unilateral field loss. If you have a central lesion, you will have a bitemporal hemianopia. And if you have the same size field loss, like only the right side is gone, you are going back into the optic, pathways and probably the cortical areas. And these are the various places where the optic nerve pathways and the projections and the cortex can get involved and can produce various kind of defects. And the most important reasons, as we just talked about the pituitary adenoma, the other are meningiomas and craniopharyngiomas in adults. If you are talking about children, you will find that there are several other pathologies, and as an interest, I have encountered so many of them. I'll probably show you some of them. We all think that we know all this today, but the fact is that Cushing actually talked about bitemporal hemianopia being the essential feature of pituitary adenoma more than 100 years ago. And not only did he describe that pituitary adenoma produces bitemporal hemianopia, he said that Cushing divided this already into 2 groups. At the time when no other studies were available, he said that bitemporal hemianopia, optic atrophy, and enlargement of the sella turcica, patient has a pituitary tumor. And usually you will have a superior quadrantanopia. He has gone that much specific. And he says that in the second group where there is bitemporal hemianopia, optic atrophy, but the sella is not enlarged and it is mainly inferior quadrantanopia, you are dealing with essentially supracellular tumor like a craniopharyngioma. So I think these basics were understood even before we had all these digital images and all other important investigations as we have today. One of the other things which almost all old-time examiners will ask you is what is Foster-Kennedy syndrome? And if you are dealing with a skull base in anterior cranial fossa, you must know this. And it is a syndrome which describes the clinical syndrome. Will anybody tell me? I already have the on your screen, so you just have to read it, I suppose. But the two essential features are ipsilateral optic nerve atrophy on the side of the lesion and contralateral papilledema, and many a times this can be associated with features of raised intracranial pressure, and occasionally it may be associated with ipsilateral anosmia as well. So let us see some of the typical examples of pituitary tumor, or how do we actually look at it. So this is a older male who presented with gradually progressive visual loss. In fact, it went to this extent that he got his both cataracts removed before he came to us, that none of this has helped. And you find that he had a temporal hemianopia which was not recognized on earlier examination before his cataract surgery, and then they found that he had a temporal hemianopia on one side and the other side vision was fairly well deteriorated. All other signs were normal. He had this kind of a tumor. So can anybody describe this tumor on T1 and T2 weighted images for me, please? Especially the intensity changes between T1 and T2.
Yeah. Come on, Lakshya, Dr. Lakshya.
Sir,
T1.
T1 iso intense and T2 heterogeneously hyper intense kind of a tumor with the areas
So
of.
it is not hyper intense. Typically, we wish it to be hyper intense, but this is becoming hypo intense compared to T1 weighted images. And this is a red flag for many patients, because this can be either due to the tumor being very containing very less fluid, that is a fibrous kind of a tumor, or second possibility,
Highly vascular.
correct. So then we look at the contrast images. What do you think now?
Well encapsulated cellular and supracellular tumor with areas of with heterogeneous contrast enhancement, and it is reaching almost the floor of the third ventricle.
Right. Now there are two important things to mention here. One is, as Dr. Goel would appreciate and tell you, that you have a very uniform upper margin of the tumor, which tells you that the diaphragm is intact in spite of the tumor being so large. And secondly, the hyperintensity of the tumor, the contrast enhancement of the tumor is not uniform. You find that the contrast enhancement is much higher at the periphery than in the center. So there is a possibility that we may have some necrotic areas within the tumor. Can you identify normal pituitary here? This was your sagittal, this is your coronal. So most of the normal pituitary, as you can see, the enhancement, it is lying at the back. And when you see your images, you find that this is a very thin line, but you will find the normal pituitary there, I can assure you that. Flare images are not so important, but sometimes you can actually see blood products within, which give you some idea if patient has had apoplexy. So when you look at the pituitary tumor, what you look at is its relationship with the chiasm, its relationship with the on the coronal images with the cavernous sinuses, and how it is looking. Do you have a kind of irregular top, or do you have a regular top? Do you have a nodules going on the sides beyond the carotid? This is what you are looking for. This tumor is becoming slightly hyperintense on T2 weighted images, so more favorable in terms of sucking the tumor out. And then you look at the normal pituitary gland, which is here, and this is the normal pituitary gland over here. So this is extremely important to know, and you can actually preserve the normal pituitary gland, whatever the size of the tumor, if you are careful looking at it. And then you also need to see the CTPNS for the obvious reasons we talked about, because an eccentric septum can misdirect you to inside that you may not follow the center of the tumor properly. That is equally important. Secondly, you must always see that the sella is large enough. The intercarotid distance is at least more than 1 centimeter before you attempt any kind of radical excision. I think some people can attempt it even with a smaller distance, but I would not recommend it to be done by people who are starting out with this kind of surgery, apart from seeing the configuration of the sella, aeration of the sella. We go to the second patient. Now this patient has presented again with a gradually progressive, but though it was progressive for almost 6 months, suddenly 1 week before that, she became very, very symptomatic for her visual problems. She was otherwise quite well. She had left hemianopia on confrontation, and all other signs were normal. Other hormones were normal, and mild hypocortisolemia, and this is the scan. I think the axial scan doesn't reveal very much, especially with such small images. But on T2 weighted images, you can actually see a fluid level here. Can you see it?
Right, sir.
Yes, sir.
And to see it better, you have these images which show you again, because the scan is done in sagittal image, you can actually see a vertical kind of a split. You can see dark part of the
Cutoff sign.
portion of the tumor here. What is it called? Did anybody say?
Yeah, Dr. Kevin Devani tell apoplexy.
Right. So this patient has developed apoplexy. That's why the patient has deteriorated rapidly over the last week or two. And this is the patient who had almost lost vision in one eye at the time of. So when you get a patient to give this kind of history, you can almost be certain that there has been an apoplexy in this patient. And after removing the tumor, in fact, within next 6 hours, she improved so much better in the eyes that she's very grateful. This is another young man. He actually presented with a sudden headache, visual blurring, and became drowsy and lethargic. So another patient who gives a similar kind of history and very acute history. Now this patient obviously from the history also has had apoplexy, right?
Apoplexy. Apoplexy.
Everything else is normal. By the time he has reached here, he has received some steroids. He is conscious, cooperative by this time. No other signs. Again, hypocortisolemia. No other hormonal disturbance. What do you see here? What you see here is actually that the tumor has stopped enhancing. And you can see hypointensity all around with just enhancement of the surroundings. And this can happen with another kind of apoplexy, which is called ischemic apoplexy. So you can have hemorrhagic apoplexy, which is more common. Almost 75 to 80% patients develop hemorrhagic apoplexy, but about 15 to 20% people develop ischemic apoplexy. And this is a typical example of that. Now, there is some feeling these days that these patients, if they are not too bad in terms of their vision, can probably be treated medically because this will settle down, but that is a controversial kind of a sentence. Now, this is a patient who came at the age of 10 years, and this is the scan. What do you think?
That case cleft cyst.
Now you are not seeing the intensity of a cyst here. You are seeing a homogeneous kind of enhancement. And if I show you the picture of the patient, you will understand what we are talking about. His HGH is 106 nanograms and his IGF-1 is more than 1,000. And he is at least 1.5 feet taller than both his parents. So it unfortunately has come late, but he's presented with gigantism. And after surgery, though his jaw and face became much lower, his height is not going to reduce further. But fortunately, he has achieved a remission from his high growth hormone levels. So you need to look at patient carefully. Now I have already put the mark upstairs. Sometimes you get a giant tumor. This is a 13-year-old girl who's come with this kind of a tumor. What would you do next? You will of course test the vision. This is the status of her vision. Her prolactin levels were more than 3,000. She was started on cabergoline and she was given a small dose of steroids. And you can see that within 15 days, her vision improved. You can see that one eye completely cleared up, the other eye also improved, and her growth hormone levels came down from 3,000 down to 227 within a month's time. It doesn't always work because in spite of increasing dosages, it went back and she eventually required surgery. But there are many patients who respond very well and you can get a very good visual improvement also. So currently, I think in a large prolactinoma, you usually would like to try medical treatment and see the response. What about this lesion? I am very sorry, I have not been able to erase some of this stuff. Anybody would like to describe this?
T1 hyperintense lesion.
T1 hyperintense lesion. So that is what is important. And this highly proteinaceous cyst was a Rathke's cleft cyst presenting with visual problems, and this was successfully removed, as you can see, with a transphenodal procedure.
Sir, usually Rathke's cleft cyst would be T1 hypo and T2 hyper, right? Or
correct, but it can be of different intensities. It can be T1 hyper also if
right.
there is a high proteinaceous content. This is one thing. In Rathke's cleft cyst, you can get almost CSF-like fluid, and
right.
you can get almost colloid cyst-like fluid. So
right.
it varies from, and the colloid cyst kind of fluid cysts have a thicker membrane like this one in particular. Right. This was a large Rathke's cleft cyst presented with visual failure, and we could remove this, but very, very thick material inside. Another patient, this is a 33-year-old woman whose eye movements are well. She's essentially presented with insidious onset of diminution of vision, and she's mother of 3 children with the smallest child 2 years, very poor vision in the right eye, and could not chart it properly even in the left eye. And this is the kind of scan which you see. Can you see a lesion here? It's right. Hypo intense on T1 weighted images. You can see it is mixed intensity on T2 weighted images. It is not extending into sella. So that is important to see. What do you think are the possibilities and what further investigation you would do?
Dr. Anish?
Heard
possibility 1, 2, 3.
Sir, the supracellular location, maybe causing hydrocephalus, a third ventricle colloid cyst, or
No. Colloid
like
cyst
craniopharyngioma.
Craniopharyngioma is one possibility. Yes.
Optic gliomas.
Right. So these are the two main possibilities in this patient. Optic glioma, nowadays people call it optic hypothalamic gliomas together. This is what it looks on
There.
FLAIR images. You can see active hydrocephalus and you can see lesion going from supracellular lesion into the third ventricle. This is how it enhanced. Now any further thoughts on this?
Is it optic pathway hypothalamic glioma?
Exactly. So this turned out to be optic pathway hypothalamic. We actually went for this patient not by subfrontal route, but not to disturb the optic pathways. We went through the ventricle, decompressed this tumor, and this is a post-operative scan which shows that I was surprised to see, however, that there was calcification which we could not decipher so well on the scan. Otherwise, I would have thought of a craniopharyngioma. But the heterogeneity was probably that, though our imaging experts could not tell us about the. So you can get actually a pilocytic astrocytoma can occasionally have calcification.
Yeah.
Sir, would there be any importance for restriction, diffusion restriction in such tumors?
Absolutely. So, do we have a diffusion weighted image? Unfortunately, I've forgotten to put diffusion weighted image, but there was no diffusion restriction in this lesion.
So what was the biopsy in here? What was the biopsy, sir, in this case?
Biopsy in this patient has been a low-grade glioma,
Okay.
not strictly pilocytic.
Right.
So this patient has had a partial resection, which has relieved her hydrocephalus, and thereafter she is receiving radiation.
Right.
यहाँ है ना, diffusion weighted है.
Yeah. This one. So not non-restricted.
So any pituitary tumors would you you would have encountered having a large tumor with supracellular extension with diffusion restrictions?
No, I cannot remember. But I have seriously not looked at diffusion restriction in pituitary tumors, I must say.
Rishabh, I think diffusion restriction usually you see either in inflammatory or very high grade necrotic area. So either there is an abscess, something like that, or very high grade tumor, which is very, very unusual there. So I don't think so. Means diffusion have so much role, right, sir?
That's what I also think. We don't regularly do diffusion restriction images in pituitary tumors, but maybe I would start looking at it and maybe ask it to be done.
So any fibrous tumor, high grade fibrous tumor appearing with diffusion restriction?
As I said, I do not have any idea, but if you feel that it helps, we will probably try it out in few patients. Dr. Goyal, do you use this criteria?
Saris, I guess, maybe on call.
So now this is another patient who has come with visual failure, and this is what it looks like on MRI. What do you think? I have already written there that the child has neurofibromatosis. So that is a giveaway. And how do we treat this patient?
It is very interesting, to decide, particularly decision, optic nerve glioma, single and multiple. So very, very important here. We can see the tumor in the chiasma with one side of optic nerve.
Correct. So how do we treat this patient? This patient I have seen, to be precise, in 1997, when she was 3 years old, and parents thought that she was not seeing so well.
So
And she had formifruste neurofibromatosis.
can I answer, sir?
Yeah.
So what we followed in SEBJ, what our teacher taught, that if tumor is single and involving the optic nerve with vision loss, of course we should excise the optic nerve and we should completely excise the tumor with complete vision loss and if patient is blind. If it is a multiple tumor, if it is involving the chiasma, then I think it is chiasma hypothalamic rather than optic glioma pure, then we should follow only chemoradiotherapy or decompression on one side if there is a bilateral partial vision loss. That we follow.
So you are absolutely right, except for one fact that the criteria differ when we talk about patients with neurofibromatosis.
Right.
In neurofibromatosis, it is very well known that tumors can even involute. And therefore, we did not treat this patient, and she is now more than 25 years old. And there has not been any growth, and the lesion has remained the same.
Okay.
This is another patient at the age of 10 years. And this tumor actually, she continued to get worse. And this patient actually had involvement of both the sides, one side more than the other. But this continued to become bigger. And this patient was treated with chemotherapy and the tumor responded quite well. Now we'll see another patient. This patient was having diminution of vision for 4 to 5 months, a 14-year-old girl, and this was the scan. So we are definitely dealing with a cellular, supracellular kind of a tumor. Fundus was normal. There were no neurocutaneous markers. This was the hormone profile. There's some hypocortisolism. HGH levels are also low. This is the scan, CT. You can see a little bit of calcification here. And you can see a cystic lesion here. This is the coronal scan. Any guesses?
Anish, Akshay, Vibha.
Looks most likely a craniopharyngioma, sir. Going by the presence of calcifications and the cystic.
You can see some calcification in a kind of a bulky kind of a tumor. And when we did MRI, this is what we see. This is the cystic component. This is the solid component. Could still be craniopharyngioma. And then when you give, you can see this fluffy kind of a tumor, not well demarcated, not very well demarcated margins.
So the tumors lies in the hypothalamus.
Correct.
Yeah. Hamartoma.
Hamartoma is something which
Very young.
usually does not present like this and does not present with visual failure. I have not seen a single hypothalamic hamartoma presenting with visual failure. So this is the, you can see the variegated kind of appearance. So I think craniopharyngioma still remains on the card. Pituitary is at the bottom here, but there is a possibility that this could be a hypothalamic tumor.
Tumor, mainly pilocytic glioma, maybe possibility.
Right. So we went ahead to operate. I don't know if the video works. Actually,
Yeah, it's worked.
I did not want to.
Very well, sir.
Okay. You can actually see a nodular growth coming from the visual apparatus itself. And it was multinodular kind of a thing without damaging the vasculature. It is being gradually removed. Chunks of tumor could be removed. And once you have decompressed the optic, it seems to be originating from the optic chiasm itself. This was a post-operative picture. And this turned out to be actually a ganglioglioma.
Oh,
so
interesting.
3 cases we have operated so far of optic ganglioglioma. And two of them have had conformal radiation and have responded well. One patient is just being observed and there has been no further growth so far. This is another patient, very, very similar. This lady came to us with obesity and visual failure, and this also showed some calcification. You can see it is almost within the hypothalamus, and the tumor was actually surrounding the carotid artery, and this could be excised. This is the scan after 3 years follow-up when the tumor has residual tumor has remained stable, but she received radiotherapy at that time, and she's quite well, except for some hormonal treatment. This is one of the large hypothalamic essentially tumor I have seen. The patient had no visual failure whatsoever in spite of having such a large tumor here. And therefore, I actually did an intraventricular biopsy first. And this turned out to be a pilocytic astrocytoma. We did a radical resection, and the child is doing well now, about 17 years old now. And this is another rare case. So you can get all kinds of tumors, especially in children, 7-year-old, presenting mainly with visual failure. And this turned out to be a PNET. And this responded well to chemotherapy, surprisingly, after a biopsy. This is another patient who has come with visual failure, bitemporal, but not very symmetrical hemianopia. Any guesses what it is? Iso-intense on T1 weighted images. These are the T2 weighted images. Can you see the lesion here? Denting the visual apparatus up. This is the T2 weighted image, turning hyperintense. The giveaway is the diffusion restriction.
This one is diffusion restriction.
So what is it?
Epidermoid cyst.
Right. So this was an epidermoid cyst. He actually got out transphenodally. You can see it. Removed it radically from the carotid and optic apparatus till we got a smooth arachnoid there, post-operative scan. How about this? Here I think I have already. So this is one of the tumors I have treated, typically presented with premature precocious puberty and gelastic seizures. So this is a classical hypothalamic hamartoma, and at that stage we did not have RF or anything. I managed to remove this tumor reasonably well, which has reduced his behavioral disturbances considerably and reduced his seizures also considerably. These are the operative pictures from that time. Another patient, you can see the tumor with multiple small cysts. Any guesses?
Cranial.
About 7-year-old.
Anyone loud and clearly?
Pilocytic astrocytoma.
Pilocytic astrocytoma. So whenever you have a lesion which is enhancing so well, which is situated in this area, what other, especially in young children, what other possibilities exist? Give me differential diagnosis of an enhancing lesion, essentially supracellular. This has not gone into the cellular really. You can see a normal pituitary below. Pilocytic astrocytoma is one of hypothalamic. I mean, it could be pilocytic, pyelomyxoid, or whatever. Optochiasmal hypothalamic tumor. What else? We have
Really,
seen a
germ cell tumor.
hamartoma. Hamartoma does not enhance, typically does not enhance. You have a brightly enhancing tumor. Anything else apart from glioma?
Okay,
A germ cell tumor.
Germinoma can be there.
Germinoma. Germinoma.
Right, right. A germ cell tumor. So how would you investigate?
Serum markers.
CSF markers.
Beta HCG, beta HCG,
Right.
and
So serum markers were negative in this patient. Rather than doing a lumbar puncture, because the ventricles were large, we went and we did a biopsy and did a ventricular CSF. And this was a germ cell tumor, and you can see in 3 months the tumor has disappeared. It was so chemosensitive. Another patient. This is the scan of this same patient after 3 months of chemotherapy. 3 shots of chemotherapy. This is another patient which was
germinoma.
again a germinoma, which was this patient actually presented with cachexia, and we thought it would be hypothalamic glioma. This patient did not have hydrocephalus, so I had to go subfrontal to take a biopsy of this tumor, and as the frozen section showed germinoma, we did not go for any further surgery because some of the tumors of they are usually of hypothalamus midbrain kind of a tumor which present with cachexia, and there the outcome is usually not very good. But this germinoma responded again very well to chemotherapy, and patient has done quite well. How about this? This is an adult. This is a 49-year-old lady who has presented again with blindness in one eye and now progressive diminution of vision in the other eye.
Look at the bone.
Sorry?
No, I'm telling them, giving the hint that look at the bone.
Meningoma. Meningoma.
So meningoma is the second most common tumor in adults, and just to top it, I think you've got a very nice hyperostosis to give you further clue apart from its proper contour, which you can see here. CT scan shows a nice hyperostosis. This one.
Also meningoma.
Also.
So there is a controversy for this kind of tumor now, how to operate on these patients. Dr. Jayesh will tell us, or one of the student panelists will tell us.
Yeah.
Endoscopy versus open craniotomy, and
Yeah, that is.
Dr. Atul is still there, or?
Both. We can do both approach, same setting. We can go intranasally and also by perional.
Question is when open, when endoscopic. That is
Correct.
one controversy.
depends on the extension. So from the midline, if it is going more laterally, then craniotomy would be a better idea.
So
Could
that
this
is
be
one
done with an
criteria, the lateral extension. If it is crossing the optic nerve, you will not go endonasal. Second is how well your sphenoid sinus is aerated. What else?
The sella is wide enough.
Sella is wide enough. Number 3, yes. So I see intercarotid distance should be about 12 millimeters. That is the criteria which has been put by Dr. Shekhar for this kind of determination. One more factor has been added by this group from California. They are saying that you should also look at the angle of the anterior cranial fossa to the sella. A deepened sella with tuberculum angle of less than 135 favors endonasal removal because you cannot see the tumor which is originating just below the planum into the anterior wall of the sella. Sometimes the tumor does flow over and you need to remove that kind of a tumor. So these are the 3 or 4 factors which decide.
One point just what would like to add, sir. If in T2 weighted, we can see that it is a very fibrous tumor sometimes. And if we are in the beginner stage, Definitely.
I think hyperostosis, fibrous tumors can be probably taken as a criteria not to go for it. And
kind of
another one will be
relative.
a dural tail, which goes much beyond.
Right.
This is a post-op. This went off quite well. Now this one. So this is our criteria today. I mean, if I get this kind of a tumor, you can see a steep sella. This tumor we did endonasal, and a relatively small tumor. And this is a tumor which is going beyond the carotid, which is going beyond the optic nerve. You can actually see that the anterior cerebral arteries were the carotid bifurcation was actually within the tumor. So this we decided to go terional to excise this tumor completely.
Just for resident, the recurrent tumor, always try to go for cranial, because in recurrence there is a fibrosis and the adventitia of the vessel will involve with the tumor. Very difficult to separate from endonasally. Agree, sir?
Yeah. Now, there are some tumors which can again cause you a lot of confusion. This is one of them. What is it?
Sir, आपने सब में diagnosis
Craniopharyngioma.
This is clearly a craniopharyngioma, but what kind of craniopharyngioma?
Yeah, that is very important question.
Cystic, so. Adamantinomatosis, sir, it's cystic.
Right. So it is a cystic craniopharyngioma. And is it essentially supracellular or intraventricular?
Intraventricular.
Left.
Supracellular.
It's within the third ventricle.
Though it is in the third ventricle, it is coming into the supracellular region and it is essentially a cystic tumor. So we actually did this endonasal, as you can see from the fat which is put here. So it is not the upper margin. Where the lower margin of the tumor is, I think determines where you get it out from.
Yeah, and sometimes retrochiasmatic tumor, we can say post-infundibular tumor is very difficult to excise from endonasally in craniopharyngiomas, right?
Correct. So a corridor in front of the pituitary, I think, is a very good indication to go for this kind of a tumor. This is another predominantly cystic craniopharyngioma, as you can see with this calcification, etc. So currently, I actually go intraventricular, drain the cyst, and then remove the solid component from nasal approach. So I am doing a two-stage approach for this kind of tumors. This is a 5 years follow-up of the same patient, and it has remained well.
Sir, in such kind of cases which you showed, the adamantinous craniopharyngioma, supracellular cystic lesion.
Yeah.
Do you advocate going transventricular, aspirating the cyst and injecting bleomycin into it?
I have done this in a few patients, almost 7 patients I have done, and actually yesterday only I operated on one craniopharyngioma where I'm going to do that. But I do it mainly for patients who are otherwise have had previous surgeries. Primary upfront, I will do intracystic therapy only for patients under the age of 5, where we do not give radiation. And where you do not, and if they are hormonally intact, then I do aspiration and then I do this instillation, and till they become about 7 years old, after which I would either try radical excision, or if they have not grown at all, then I would ask for a radiation treatment, because this is a definitive treatment. Something I'm not sure of.
Yeah.
I think it is a treatment which is very important in very young children who come with predominantly cystic tumor, and where you need not do a very major surgery. They respond very well to cyst aspiration, and the cyst remains dormant for somewhere between 2 to 3 years. That has been my experience of about 7 cases so far.
And probably recurrent craniopharyngioma, which is third time coming, and you have no, I think so, that then it will work maybe.
Correct. This also gives you one major advantage, that when these patients go for surgery, they do not have a large cyst. You know, even radiotherapists will tell you that they have to keep on changing their plan in patients who have got cystic craniopharyngioma, because cyst very rapidly changes size. One advantage that happens after installation of alpha interferon currently, earlier we have used bleomycin in 2 patients, but it is toxic, so we don't use it anymore. Is that the most of the recurrences then become solid and they are thick walled, so they are either good for good radiotherapy targets, or they are good for even surgical excision if you can manage.
Right.
Iso-intense even on T2 weighted images. What do you think?
It'd still be hypothalamic hematoma.
Sorry?
So contrast enhancement.
Contrast enhancement here. It is not at all enhancing.
Hypothalamic hematoma.
I think that is T1, right, sir? That image is T1.
This image is T1.
Yeah.
This image is T2. This image is contrast.
Okay. Okay.
Actually, I thought this would be a craniopharyngoma, to tell you frankly. Sometimes the non-enhancement is something which has to enhance somewhere. The fact that there was no calcium and there was no enhancement at all, we were not sure what we are dealing with. We also thought of Rathke's cleft cyst, to tell you frankly,
Right.
but this turned out to be an arachnoid cyst.
But
This has been very nicely
yeah,
tackled with.
In T2 weighted, it is completely, you know.
So that is something which I am still nothing else whatsoever.
Oh my God.
So sometimes a static CSF can look a little darker. That is what explanation.
Even we can see in the first row that there is a kind of head.
Actually, this is a very good point which you have come out with. I did not keep the video in this because essentially I thought I will just discuss the plethora of cases rather than surgical technique. But this was actually the stalk of the patient, stalk of the pituitary. And I had to go on either side to get the, do a marsupialization of this cyst. So I have marsupialized the cyst behind the infundibulum.
So it means maybe the
understand that
because of thick content of the CSF, maybe some that would be the reason of this.
Yeah, but I mean, this was a googly. I didn't anticipate it, and I am really surprised that the wall has not shown any cuboidal epithelium. I seriously expected this to be a Rathke's cleft cyst, because there also you can get sometimes very clean fluid.
Right. Very interesting.
Now, this is another thing. This patient has a supracellular tumor, and he's presented not only with visual deficit, but also 6 nerve paresis. And if you look at the CT images, what do you find?
Erosion.
You find a lot of bony erosion. And you can see that the whole diaphragm ocelli has been eroded, top of the clivus is eroded. So the diagnosis?
Chordoma.
Clival chordoma.
Right, clival chordoma is the most likely diagnosis. The only differential diagnosis in such patients is, I have been fooled by it a few times.
Giant cell tumor.
Sorry?
Giant cell tumor.
Giant cell tumor is a small possibility. Giant pituitary adenoma, especially prolactinomas, I have seen, they can invade the bone very badly.
So what is the age of this patient?
This patient was about 26.
Okay, means adult patient, right?
We have seen such kind of a case recently, and the reason why I kept on asking about diffusion restriction was such kind of case had a diffusion restriction in our
Sphenoid sphenoid mucocele you found.
no sir, diffusion restriction with the destruction of the sella and the sphenoid sinus, and similar kind of picture on the scan.
And what did it turn out to be?
It has turned out to be pituitary adenoma on the frozen, sir, as of now. We are waiting for the final report.
Prolactin levels?
But the prolactin levels were not very high, sir. They were 60 for this level, and the patient also had low cortisol.
Okay. Most of the bony eroding tumors I have seen. Is Dr. Goel there? I cannot see it on my screen.
Sir, it's not there.
He's not there.
Right.
Most of the cases I have seen with extensive bone erosion with pituitary tumors have really been prolactinoma. So please check with double dilution and whatever else.
Invasive pituitary adenoma is very
Yeah.
common.
This is another chordoma for you. You can see almost amputation of the top of the clivus with the tumor. This patient also presented with visual deficit and isolated 6-nerve paresis. So that is a giveaway many a times. Apart from, and I think you must do a CT in these patients to make sure. I will not take you through this video, but we could manage to remove the tumor and save the pituitary stalk, etc. So I think we have seen a variety of lesions. If you really have a case like I had for my MCH exit exam, I had a case of supracellular tumor as a long case, and then it becomes very difficult. So you better know what kind of defect you can get in optic tracts and how is the configuration of optic fibers. It is beautifully described in many books. So I would strongly recommend you. I'll be happy with optic nerve involvement, chiasm involvement, and optic tract involvement if you can differentiate that much, but some people might insist more than that. And the location and the tumor and your surgical approach becomes extremely important. And though the endonasal approach is increasing, I think we discussed in a few cases where you should avoid it and where you should take it. And this debate is maximally used for meningiomas, where we still do not know what is the best way to do it. I think like we know for sure today that pituitary tumors and many of the chordomas which are strictly in midline should be tackled endonasally. In craniopharyngiomas, it is probably equally divided. Some can be done better than endonasal approach than the transcranial approach, but transcranial approach still remains a favorite approach. In meningiomas, I think predominantly the transcranial approach, very little endonasal approach, but there are more and more indications emerging for this. So this slide will keep on changing as our technology keeps on improving and expertise keeps on improving for these kind of surgeries. I think I'll stop here. Thank you.
Thank you, sir.
So, before we close, sir, there was one very interesting question asked by Dr. Achal, that with optic nerve glioma in pediatric patient who is unable to appreciate some diminution of vision, but has torticollis and squint to compensate, and radiology showing unilateral optic nerve glioma extending posteriorly up to chiasma in case of NF2, should we, neurofibromatosis, should we wait or watch? The same thing we discussed.
So, I think the most important point you said at the end, in neurofibroma patient. In neurofibroma patient, I would still be conservative. I would still think of, unless the patient has a very bad proptosis and the eye is at risk because of the mechanical reason, I am not very keen to operate on a neurofibromatosis patient. If this is a patient without neurofibromatosis, I will amputate the optic nerve at the level of chiasm, and I have actually done a removal of the globe as well as removal of the whole nerve. I have done, but only 2 children I have been able to do this kind of surgery, because most of the patients who have preserved vision, you do not want to do this kind of surgery. And surprisingly, in low-grade glioma of optic chiasm, chemotherapy has been fairly successful. So surgery unless you really have very strict criteria, unilateral optic nerve glioma, stopping short of the chiasm, presenting with proptosis apart and is completely blind. I think if these criteria are fulfilled, then you may consider radical surgery. Dr. Sardana has disappeared after asking the question.
No, I think, sir, his because of internet connection and probably something he would have.
But these are my criteria for using that. There is also a little bit of controversy as to what is better, either radiation or chemotherapy. I think in neurofibromatosis and non-neurofibromatosis cases, the chemosensitivity is different. And therefore, Jayesh, you have anything to comment on this one?
No, sir. I completely agree. Completely agree.
So I think you have to treat NF and non-NF patients separately, and you have to really think of radical surgery only with these 3 or 4 criteria.
Right.
Actually, sir, I have a question.
Yes, Achal, speak loudly.
Sir, my basic concern was that pediatric patients are not able to appreciate that.
Achal, we are not able to hear you. You can write it down in the chat box. We can read it.
Any other questions from the panel who was presenting? Anish, Lakshya, Vibha, or anyone from the audience who would like to ask anything before we conclude the session?
Okay, fine, Rishabh. I think. So it was, sir, we are so grateful to you. We have learned a lot. It was a series of rare, unusual, and very interesting cases. And at the end, we have, we have shown complete picture of supracellular clinically and some extent radiologically, differential diagnosis, and we also you cleared that should go for endoscopy, should we go for transcranial. And thank you so much for your time, sir.
Most welcome. I am personally not very happy with my presentation because I was a little bit confused as to what you would be interested in.
But sir, I think it was what was needed. It was you have given more than that.
Yes, sir. Actually, sir, I think the students have benefited more with what you had presented rather than what you would have hoped it to be.
Okay. Sir, Achal has right that comment. My basic question was that pediatric patients are not able to appreciate diminution of vision. Correct. And vision is one of the most important criteria in deciding management, whether surgical or chemo. So
absolutely right. So I think VEP is used by many people as one of the criteria. And I think a child below above 2 years of age, you can probably interpret VEP reasonably well.
Right.
That can be used as a criteria.
Right. Thank you, sir.
Can everybody just switch on their video cameras?
If possible, of course.
So on the count of 3, I'll be clicking a picture. Can we have all the participants switching on their video cameras? Yeah. So 3, 2, 1. For the next, yeah. Yes, thank you very much, everybody. Thank you, Dev Pujari, sir. It's been an honor to have you on board, sir. It was a very helpful session, and I'm very sure everybody has benefited.
And particularly Dr. Vibha, Anish and Lakshya has done a wonderful
Yeah.
job.
Wonderful job.
Thank you, sir.